surgical management of pediatric thyroid cancer, how to reduce complications. And then we also have a session on what are the lifetime risks associated with the use of RAI therapy during childhood and adolescence. So I'm happy to welcome two of our doctors today who will be presenting. The first is Dr. Ken Kazahaya, and he is an Associate Director of the Division of Pediatric Otolaryngology, Director of Pediatric Skull-Base Surgery, Medical Director of the Pediatric Cochlear Implant Program, and co-lead surgeon in the Pediatric Thyroid Center at the Children's Hospital of Philadelphia in Philadelphia, Pennsylvania. He also has an appointment as Associate Professor of Clinical Otorhinolaryngology, Head and Neck Surgery at the Perelman School of Medicine at the University of Pennsylvania. Dr. Kazahaya specializes in otology, cochlear implantation, skull-base surgery, thyroid surgery, pediatric head and neck oncology, and facial plastic and reconstructive surgery. He has numerous publications in peer-reviewed journals and has been an invited lecturer nationally as well as internationally. So welcome. We also have Dr. Adina Alazraki. She is a pediatric radiologist at Emory University School of Medicine and Children's Hospital Healthcare of Atlanta, both in Atlanta, Georgia. She attended and graduated from Emory University School of Medicine and completed a residency in pediatrics. After 5 years in practice in a busy emergency room, she returned to Emory to complete a radiology residency and pediatric radiology fellowship. Her expertise spans from pediatric body MRI to nuclear medicine, including therapies in all facets of oncologic imaging. She serves as a member of the ATA Pediatric Guidelines Task Force, the chair for the Oncology Committee of the Society for Pediatric Radiology, and executive board member for the Pediatric Imaging Council to the Society of Nuclear Medicine and Molecular Imaging and the section of radiology for the AAP. She's currently the director for MRI and nuclear medicine at Children's Healthcare of Atlanta. So welcome to you both, and thank you so much for your time.
Thank you. And let me just share my screen here. And we'll get going. All right. Well, thank you very much. And I want to thank ThyCa and Gary Bloom for the invitation to speak today on talking a little bit about thyroid surgery and how to reduce complications in that venue. No disclosures. And so the 2015, the American Thyroid Association came out with a management guideline for children with thyroid nodules. And in that, they would discuss like who should really manage children with thyroid nodules and thyroid cancer. And the recommendation in there was that children should be cared for by teams of physicians experienced in the management of differentiated thyroid carcinoma. Also, really, the reason for that was to really facilitate optimal therapy, preoperative diagnosis, the management of the actual lesion, and then also the treatment and long-term follow-up. And this was really to optimize, trying to make sure that these individuals and these children were not overtreated or undertreated because of individuals that may not have had as much experience with care for these processes. So really, when you look at that, these kids really should be taken care of at a full spectrum pediatric specialty care center with full group people, endocrinology, radiology, high volume thyroid surgeons, anesthesia, as well as nuclear medicine, PICU. These are all very important and should be well versed in the care of children and care of children with thyroid disorders. So we know that when we look at pediatric endocrine surgery, there's lots of papers out there talking about risks of complications from surgery. We do know that complications in children is higher by report than in adults, and that there was some papers that have come out looking at how to reduce this risk, and have found that if you have a high volume surgeon, that you could potentially reduce the risk of complications. And the number was pulled out kind of like almost arbitrarily, that greater than 30 thyroid surgeries per year by Dr. Tuggle back in 2008. Now we kind of look at these things and say the number should be anywhere from 20 to 30 neck procedures has been accepted by some other groups. But in a paper put out by Dr. Souza, and also that same year, looked at some of the clinical outcomes with children having thyroid and parathyroid surgery. They do note, as you say here, the lower age groups of children do have much higher rates of complications, which then portends a longer length of stay in the hospital and higher overall costs. Once again, also these younger age groups, you have much higher rates of recurrent nerve injury, and also much higher rates of both transient and permanent hypocalcemia. We put out a review of about 444 thyroid surgeries that we performed over an 8-year period of time, looking at the complication rates of our patients. The average age was about 14.3 years of age. Looking at total thyroidectomies, we had 332. And then of that, we have about 1.7% had temporary recurrent nerve injury with recovery, and then but only 0.6% permanent recurrent nerve injury, and once again for the hypoparathyroidism, only 0.86%. So we have only 2 surgeons at our institution performing all the thyroidectomies. So each one of us does about 40 to 50 thyroids per year to really maintain that high volume practice. I think that is a very important part of it, that we're well versed in the care of the surgical management. But some special considerations for pediatrics when looking at kids, and is you have to remember that they come in all shapes and sizes, but in particular, the really young children are going to be very small. The anatomy is going to be small. Their blood volume is much smaller than an adult, so we have to be really concerned about their blood volume and how much do you potentially lose during a particular case. Positioning of a child is very important because you don't want anything laying on the child, or you don't want the child laying in a bad position on the table, because once again, they could be much more adversely affect an adult that's laying over a larger area. Temperature regulation is very important, as they can lose heat very quickly, and if you have low body temperature during surgery, that's also a negative effect upon their and increase their complication rates. So another issue during thyroid surgery is the looking at parathyroids. In kids especially, they have a different appearance than in adults. They're very small, and they also have almost like a clear appearance, especially if they're younger and less than 5 years of age. As you get older, they get a more usual adult appearance, where it's kind of more like a caramely color. So you can actually see here's a parathyroid here in place that has that kind of like that caramely color behind it. But in younger kids, it could look just like fat. There's a lot of fat lying around this. Also, the lower part of the thyroid in younger children could be completely encased in thymus. So you could potentially have a parathyroid gland that's encased in thymus, and that you can't really see it or find it. If we devascularize these glands, we need to consider about whether or not we need to reimplant them, whether or not if they have some family history of hyperparathyroidism or MEN2A, that we may want to consider reimplanting that parathyroid in the forearm because of the high risk of development of hyperparathyroid sometime in their lifetime. If they have a low risk for hyperparathyroidism, then we may just reimplant right in the through the same incision in the sternocleidomastoid muscle to allow for that parathyroid to take hold and to reduce the risk of permanent hypoparathyroidism. Recently, there have been some use of devices to help us identify in situ the parathyroids. And fortuitously, there was an individual who was able to come up with this idea of using near-infrared light. It was a Korean gentleman that found this during one of his research projects, and it basically, using near-infrared light, we can see that the parathyroids actually glow. They have autofluorescence. You don't have to give any medications to do this, and now they're commercially available products. There are 2 available out there. One is this Fluoptics, and that can actually show you the parathyroids in place And if you have a concern about their vascularity, we can actually inject indocyanide green, and we can actually see the perfusion of the tissues and the perfusion of the blood supply to the parathyroid to make sure that they actually have adequate blood supply to them. So it really has helped in some studies be able to reduce the rate of postoperative hypocalcemia by really being able to identify them. Typically, in our situations, we use them more as a teaching tool because we have relatively good idea where the parathyroids are. But then to our residents and fellows, it's nicer for us to be able to teach them and say, look, this is it. And if they can't believe us, you just put the fluo beam on there, and then it lights it up, and then it verifies right away that it is exactly what you told them it was. So here's an example of the use of the fluo beam. You can see there's a protuberance on the thyroid, back of the thyroid gland. If you just look at it on unexperienced eyes, you wouldn't realize that this is a parathyroid right here. But when you use the fluo beam, there it is lighting up. You take a little bit of the tissues off of it, some of the connective tissue off, and it's much more visible now. So hyperparathyroid also can be due to just incidental stunning of the gland. So your way you dissect the thyroid out is very important. You really want to make sure you leave the vascularity to the parathyroids intact, and also you want to make sure you don't remove them inadvertently. Sometimes if you have the thymus coming up along the bottom of the gland, if you take that thymus out with the gland, you'll actually end up taking parathyroids with it. So typically for children, I emphasize to my residents and fellows, you need to make sure that you leave the thymus behind. There's no benefit of taking it, and if you do take it, you might actually take a parathyroid with it. We also give preoperatively vitamin D, because most children these days are vitamin D deficient, either because they're getting slathered with sunblock before they go outside, or they don't go outside enough, so they're not getting enough sun exposure, which helps create vitamin D in your body, or they're just not drinking enough milk, so they're just vitamin D deficient. So we usually give a preoperative dosing of vitamin D to help bring that up, and then we do use intraoperative monitoring of the parathyroid hormone and calcium to make sure that they're not dropping during surgery as a sort of belts and suspenders to help us post-operatively. If there's a drop in the parathyroid hormone during surgery, we can give calcium supplementation right away, and also may even be able to give intravenous calcitriol during surgery to make sure that post-operatively you don't get a dip of the calcium levels. So these are some of our indications on how we would give calcitriol. As once again, if it really dips low, the parathyroid hormone during surgery, we may give an IV dose of calcitriol in the OR, especially if we're doing like a longer case requiring a lot of dissection of the neck nodes, lateral neck compartments. And if we see a drop in the PTH during the surgery, if you wait until you've done all the surgery until they're awake and then give them calcitriol, it might be a period of time before they're able to take that, and you might see a drop in the calcium levels. So as soon as we see a drop in the PTH, we have the anesthesiologist give a dose of IV calcitriol, which then helps reduce the risk of a significant hypocalcemia postoperatively. So in the operating room, to help with analysis for postoperative management, we place a separate IV for drawing of bloods postoperatively, so that the child doesn't have to keep being stuck with the needle in order to watch for calcium levels and to be able to accurately assess it. And then we can give oral supplementations of calcium, mainly just Tums. Most kids are able to take it, especially nowadays. They have nice flavored ones. They're less chalky, so they're much more tolerant of it than they used to be. If they have really symptomatic hypocalcemia, we may need to give IV calcium. We try to avoid that, but if we do, we can use a central line placement because the calcium is very sclerotic to the veins. So if you're going to give IV calcium, we would typically have a central line placed and then transfer to the ICU for management. I bring back up the thymus again, because as I said, thymus can be quite large in individuals, that's in younger individuals. Not only can it cause some interesting nodules within the thyroid itself, because this is an intrathyroidal thymic remnant, and if you look at kind of speckled appearance, and an inexperienced individual might say it could be a concerning nodule for malignancy, but if you look at the echogenicity of this nodule with the thymus that's right next to the thyroid gland, is very similar. And so you can say this is probably more likely a intrathyroidal thymic remnant. The other thing about thymus gland, as I said before, the parathyroids can be buried in this. So if you come across it intraoperatively, you don't want to be taking the thymus inadvertently. So. In order also to help reduce complications, we want to monitor the vocal cord mobility and the nerves for the vocal cords. So there are commercially available endotracheal tubes that we can use during surgery that have monitoring electrodes on them. One is such as the Medtronic Trivantage tube. The other ones, they have stick-on contacts that you can put onto endotracheal tubes. One is called the Dragonfly. There's a C2 monitor that also is a monopolar adhesive electrode you place onto the endotracheal tube. I typically find those to be very noisy, and so it's more difficult to use those and get a good reliable signal. The other thing we can do in kids who are very small and that the endotracheal tube is too big for that typical child, we can actually place hook wire electrodes directly into the vocal cord muscles, and that way we can actually monitor the nerves to the larynx directly. The nice thing about using laryngeal nerve monitoring is that we can not only identify the nerve, but we can also map it out. So if you have a neck that has a lot of lymph nodes or a lot of disease in it, or you have a super large gland that's compressing and moving things out of the way, we can actually map the nerve out within the soft tissue without really coming near it. And that way we can decide, okay, how do we approach the nerve to get it out of that tissue safely and be able to help preserve function of that nerve. Studies have shown that you don't really reduce a risk to recurrent nerve by using monitoring, but I think it definitely does help avoid bilateral true vocal cord paralysis during surgery, because before we go to the other side, we do verify that the one side you've operated on already, that the nerve is working before you cross over to the other side. The overall risk to recurrent nerves is relatively small, but if you have an injury to one side, studies have shown that you significantly increase the potential risk to the contralateral side during the same surgical procedure. So you go from a very minimal risk, but if you've injured it on the one side, you're about a 20–30% chance the other side will also have problems. And especially in a young child, you don't want to have bilateral vocal cord paresis, because if both vocal cords aren't working well, when you try to breathe in, the vocal cord slams shut. So you need active laryngeal nerve function in order to open the voice box and allow the air to go through between the vocal cords. If you have only one side that's working, it still allows air through, but if both don't work, it doesn't allow the child to breathe, and that can be a significant problem post-operatively. So really important for us to know whether or not a nerve is functioning or how well a nerve is functioning prior to going to the contralateral side. The other nice thing about using recurrent nerve monitoring is that we can actually see when we might be irritating a nerve or coming up to a time we might be causing trauma to the nerve, because we can look at how long the nerve may take to stimulate and what type of response we're getting. So using that response peak and also how long it takes to get the response, we can say, okay, the nerve is getting a little traumatized. Let's back off the nerve, go to somewhere else, and when you come back, typically the nerve is recovered, and then you can continue on the surgery on that nerve. So it helps us to avoid a more significant praxia of the nerve. And here's a picture of using hook wire electrodes. Here's an endotracheal tube in place, the vocal cords on each side, and then you have these Teflon coated wires that we place 2 into each vocalis muscle, and we've done this under a microscope, so we really can see the vocal cords and really place the electrodes exactly into the muscle. When we do a recurrent disease, sometimes you might have an isolated lesion in the neck, or a couple of lesions that you may be full within the scar tissue or where you've operated before. So what we can do is intraoperatively use ultrasound guided localization of these lesions, isolate them with ultrasound, put a needle in, inject them with methylene blue. And then this allows us to really identify where the lesion of question is and concern is, so we can identify it and really make sure that we've taken out that one little node or lesion or recurrence that may be within a bunch of scar tissue, and really make it difficult to really be certain that you were able to get what you really were going after. The other thing is we do have an isolated persistent or recurrent disease or a small cystic disease. We can actually try percutaneous ethanol ablation, just under sedation or anesthesia. They can localize the lesion and actually use a needle and actually put ethanol directly into that and then to obliterate it. Something that we've been considering recently is targeted oncogene therapy before surgery in children with really advanced disease. So we've seen really good evidence of tumor regression for some cancers with oncogene-specific targeted therapies. And in some of these individuals with really advanced thyroid cancer, consideration is, should we be considering using some of these targeted oncogene-specific therapies prior to going into surgery? And the reason why that comes up is that we've had a couple patients who've had really what we consider an operative surgery, an operative disease, who have been treated with targeted therapy, where they have significant either complete reduction of the tumor mass, or it shrunk significantly enough where it made a once unresectable cancer into something that is now resectable or manageable surgically. So really, I think we need to be thinking about, is there time to really be considering a paradigm shift in how we treat these advanced thyroid cancers? And so this really looking at things like if they're encasing neurovascular structures or on the aerodigestive tract, or if they're having significant pulmonary burden, or even encasement of the trachea or the esophagus. Should we be considering some of these neuroadjuvant or oncogene-specific targeted therapy to reduce that tumor burden prior to either a surgical resection and follow-up radioactive iodine? So. Once again, for reducing complications, we really do stress that high volume centers are really important, not just high volume surgeons, to really ensure complete and accurate assessment of these nodules and lesions, and also the high volume surgeon who has experience and the difference between pediatric neck and thyroid and anatomy from the adult, the use of laryngeal nerve monitoring, and the intraoperative parathyroid hormone monitoring. And then for us, we also have the ability to insight to see the parathyroids because of the technologies that we have available to us. Also, post-operatively, we want to make sure that these children are appropriately stratified to really reduce the risk and the morbidity of post-operative management. So once again, we are doing a lot of pediatric efforts, especially along the pediatric otolaryngology community. We are starting to collaborate across the country. These are just some of the different hospitals that there are various surgeons at each hospital, and these are just some of them. There are more at each that we actually work with. And we've actually started coming together as a group to discuss the children, some of the surgeries that they've had, some of the outcomes, and we've actually developed a multi-center database for which we're going to be investigating some of these outcomes and disease processes to really come up with a more comprehensive evaluation of pediatric thyroid cancer and its surgery. There are also medical societies that are really looking into this as well and pushing forward the pediatric endocrine surgery and thyroid surgery. The American Head and Neck Society restructured recently, and they created an endocrine surgery section, of which with Dr. Randolph and Brendan Stack and Mason Shindo have really, with their support, we've been able to develop and start a pediatric endocrine surgery committee. Dr. Rastatter and I are co-chairs of that committee, and we've compiled a large multi-center database of pediatric thyroidectomy patients, looking really at the outcomes and complications of these patients. We've completed data analysis on the multifocality of pediatric thyroid cancer within, and really looking at the outcomes accordingly to over these multi-center database. And we're also going to be publishing a consensus statement regarding management of pediatric Graves' disease as a narrative review soon, and that's to be submitted, and it's in its final stages of editing. The ACE and AHNS, we've come together and with a consensus pediatric thyroid surgery statement, and that has been submitted and is undergoing peer review currently and should be available in the near future. So we're definitely seeing a greater interest and emphasis by both individuals and institutions and various societies for the management of pediatric thyroid disease in order to help manage appropriately the disease process, as well as reduce complications and minimize the post-operative morbidity and risks to these individuals. So I will harbor any questions from everybody.
So Dr. Kazahaya, we do have a few questions in the chat room.
Okay, let me see what we got here. Yep.
How long does it take for anti-thyroglobulin antibodies to decline or become undetectable after ethanol ablation?
So when our interventional radiologists do this for us, it typically would be just as with any, when we do thyroid surgery itself and we do the resection of thyroid, the thyroidectomy or neck dissection, it's no different than for an individual who's undergone that procedure. So we should see over time the thyroglobulin drop down the same rate as if we were to do a full surgery on like a thyroid. So it's not any different than that. You know.
Okay. And we also have a question from Sveti, who I know is popular. Everybody knows Sveti now.
Yeah.
Is it easier to get the thyroid out as young children or older adults, or does it vary? I know everyone has different types of thyroids, and some when they have more affected lymph nodes, but I was just wondering.
Yeah, I would say from my experience in children, I mean, we've done a lot of MEN2B prophylactic thyroidectomies in infants that are quite young, and the infant neck is the tissue planes are beautiful. They haven't been through a lot of disease process, not a lot of inflammation. Their parathyroids are tiny, and very difficult to see. But the thyroid itself is very easily dissectable from the surrounding tissue. In the young children, like in the tween age years and early teenage years, still the thyroid is very similarly. The planes are much nicer than as when you start getting the older children. Even when I remember from doing adult surgery, the planes are much nicer in children. But if you have a child with Graves' disease, that kind of throws a whole different work into, because the Graves' disease is a very vascular gland at that point. We find that it's a challenging procedure no matter what age you're at. I think for Graves' disease, it's more how active the disease is. We do find that if we place them on cold iodine or SSKI lugal solution beforehand, there is some contracture of that vascularity that does make it a little more convenient during surgery. But it does vary case to case. But I do typically find the younger children do have less. The tissue planes are better preserved for the most part, unless it's an invasive cancer and that's getting into the muscles around the thyroid, or a lot of lymph node disease where it's getting extracapsular outside the lymph nodes. In that situation, it's just as challenging.
Okay. All right. Thank you very much. That's all the questions we have for you so far.
Great. Okay.
All right. Hello and good afternoon. Thanks for having me speak. I hope everyone can hear me well. I'm going to talk to you today about the lifetime risks associated with radioactive iodine use in the setting of pediatric thyroid cancer. I'm sorry about that. I have no disclosures, and I'm going to just do a little bit of background first. Why do our pediatric patients get thyroid cancer? Thyroid cancer in pediatric patients is considered a rare disease. It's not something we see every day. And we tend to see certain populations who end up with thyroid cancer, and those might include patients who had a leukemia at a very young age and had whole body radiation or specific radiation to the neck. So patients with a history of radiation exposure, especially therapeutic radiation exposure, should be screened. Patients who have autoimmune thyroiditis also are prone to developing a higher likelihood of thyroid cancer in thyroid nodules. And then there's all these genetic predisposition syndromes, and these are have become a big concern, and a large percentage of pediatric thyroid cancer is associated with some kind of a molecular abnormality. So some of the known cancer predisposition syndromes associated with thyroid cancer include the polyposis syndromes, Carney complex. Most people, I think, in the thyroid community are very familiar with Dicer-1 and P10 hematoma tumor syndrome, but other ones like multiple endocrine neoplasia and Werner's syndrome are also associated. Pediatric thyroid cancer also can look a little bit different than adults. One of the things that the variants of thyroid cancer we see in pediatric patients is this diffuse sclerosing variant, which is what this ultrasound image is showing, where you have just the entire gland replaced with cancer, not just a nodule. So it's different. So when we see pediatric thyroid cancer, really, who gets I-131? Because should everyone get it? So the 2015, finally, the long-awaited pediatric ATA guidelines basically came out with a recommendation that I-131 is indicated in patients who have iodine-avid persistent local, regional, or nodal disease that can't be resected, or if there's known or presumed iodine-avid distant metastatic disease. So in those two populations, it really is indicated to eradicate the disease. But we did also recommend in the 2015 guidelines that we support selective rather than universal administration. So here's just a case example. This is a 5-year-old girl who had a P10 hematoma mutation and had a screening ultrasound, which identified this almost 2-centimeter nodule in the left lobe of the thyroid gland. The ultrasound, we looked for lymph nodes in the neck, and there were no nodes identified that were abnormal in the lateral necks. So the patient underwent a total thyroidectomy and central node dissection, and the nodes that were removed were all negative. So pathology reported a follicular neoplasm with capsular invasion in a less than 2-centimeter primary nodule and negative nodes. So the patient had a post-operative diagnostic whole body scan. And this is the whole body scan. And you see some salivary gland uptake, some counts in the stomach and in the bowel and in bladder, which is normal physiologic distribution for the dose that's being excreted. But we really don't see, there's very little residual in the thyroid bed and no other metastatic disease. So should this patient get treated is the question. Well, at the time, and I think most people would agree that in the setting of capsular invasion, the patient should get an iodine dose. So the question is, how much do we give? This young lady ended up getting 32 millicurie for remnant ablation. She was 17 kilos at the time. So for a 17-kilo child, 32 millicurie is not a small dose. But in the setting of, empiric therapy in the adults, it sounds like not enough. So 5 years later, she did great for 5 years and then started to have a rising thyroid globulin. So we did another whole body scan, and she was found to have a new right lower lobe pulmonary nodule. And you see the SPECT CT images there showing the nodule in the right lower lobe and the corresponding iodine uptake to that nodule on the SPECT fused image. So at this point, she's now 10 years old. She's more than double her weight. And because of the distant metastatic disease, we opted to give her a really good empiric dose of 150 millicurie. And since then, she's now again 3 years out further with undetectable thyroglobulin and doing well. So the goals of iodine therapy are really to, like anything in medicine, is to do no harm, right? So we want to maintain low mortality and decrease the risks of thyroid cancer recurrence. Ideally, we're trying to improve survival by eliminating any iodine-avid disease. So the goals of therapy really is to reduce the potential of post-therapy complication when you talk about dose. So like Dr. Kazahaya already talked about, we want to try and engage a high-volume thyroid surgeon. We want to have a complete thyroid tumor board and team of physicians, like Dr. Kazahaya mentioned, with an expert in nuclear medicine, in endocrinology. And we really want to have a multidisciplinary tumor board team where we talk about these cases and really decide collectively what the best approach is for the patient, using really selective use of iodine, not just universal use. This patient that I'm showing you here had, she had whole body radiation as an infant for leukemia, and developed a very sticky thyroid cancer in her neck. It was a diffuse sclerosing variant, but it was very difficult surgery. It was a rock hard cancer, and it was a very difficult surgery. So we knew she was going to have some remnant in the thyroid bed. This was her pre-ablation scan. And on the pre-ablation scan, we noted this focus that looked like it was in the head. And it wasn't sure exactly where it was. She was otherwise asymptomatic. So she went on to get a brain MRI. And you see there in the left parietal, she had a metastatic lesion here. And the importance of that was we were able to sort of redirect her treatment at that point. She went on to have the nodule resected prior to getting her ablative dose. So one of the things that we did, that the ATA guidelines recommended, is risk stratification for these patients. So meaning that we want to risk stratify to decide who needs iodine and who doesn't, and what kind of surgeries to do, and all of those components go into the results of risk stratification. So the low risk was defined as a confined thyroid cancer to the lobe with no capsular invasion, with negative nodes or no known positive nodes, or possibly incidental loco-regional micrometastases. Intermediate risk are cancers that have extensive loco-regional nodal disease and minimal distant nodal disease or distant metastatic disease. And then the high risk have extensive metastatic disease. So why do we risk stratify? Again, we risk stratify so that we can direct the therapy, because we're trying to promote the use of selective I-131, not universal. So low risk patients, it is recommended that they are initially assessed with a whole body scan, but followed with TSH suppressed thyroglobulin alone. Intermediate and high risk patients will get a whole body scan and stimulated thyroglobulin levels to assess for persistent disease. And in all patients, neck ultrasound and or when you're doing I-131 whole body imaging to get hybrid SPECT-CT imaging to conjunctively localize where disease is, if disease is found. So the purpose of ablation for that post-surgical remnant is to decrease recurrence and improve survival. And that has been shown that in tumors that are greater than 1 centimeter in size, where there's vascular or capsular invasion, or in poorly differentiated or Hürther cell carcinomas, that the ablation of the remnant does decrease recurrence and improve survival. So other patients who benefit from that are patients with lymph node metastases and younger patients, and particularly older patients. The bottom line, though, and what makes these decisions somewhat difficult, I think, for the team, is that despite everything, prognosis is still favorable regardless of adjunctive therapy. So there are arguments against universal I-131 administration, and the main arguments against it are because of the short and long-term toxicities of high-dose I-131, and high dose meaning more than 100 millicurie. In the short term, these may be nausea, vomiting, sialadenitis, transient amenorrhea in girls, and decreased spermatogenesis in boys, and transient bone marrow suppression. But the bottom line is that there's really a lack of data that conclusively shows benefit of adjunctive therapy, and that's what makes these decisions really difficult. There is a dose-dependent increase in the risk for secondary malignancy development, and I'll talk more about that. And thyroglobulin can still be useful and become undetectable after total thyroidectomy, even without I-131 ablation. So the advantages of the post-operative remnant ablation is So these are in patients who have no metastatic disease. It does decrease the risk for recurrent local regional disease, and it might facilitate long-term surveillance with whole body iodine scans and stimulated thyroglobulin measurements. Ultimately, we're trying to improve patient management. So what are the risks of radiation? So these are sort of general terms, but the excess risk for solid tumors from the Nagasaki and Hiroshima population followed a dose response curve, and that's that purple curve C, which is a linear quadratic curve, showing that once you reach a high enough radiation dose, your cancer risks increase significantly. And from those populations, we saw that children were particularly vulnerable to developing thyroid neoplasms, and women who were younger than 15 at the time of exposure had significantly increased risk for developing breast cancer in later years. So it's often difficult to extrapolate what the real risk of a secondary cancer from a therapeutic dose of I-131 to these general radiation exposures in Hiroshima and Nagasaki. So some have tried to compare it to environmental exposures specifically of I-131. So some of the major I-131 releases in the environment are these top three are sort of listed below, and some of these are over many, many years. As you can see, specifically the Chernobyl accident in 1986 released 50 million curies of I-131 into the environment. And what the Department of Health and Human Resources and Human Services determined was that the amount of I-131 available to expose a person after that release depended on a lot of other factors, which aside from just the amount released, but the distance between the populated area and the place of release, the height of the release, because that affects how far it's carried and how far it settles to the ground and versus going to the environment, and the meteorologic conditions at the time of the release. So wind, rain, all those things can affect really what the actual exposure is. So the measurement of actual exposure is very difficult, I think, even in known specific iodine exposures. So it's very hard to correlate. So when we talk about environmental exposures compared to therapeutic exposures, it's very hard to make direct correlation. So one of the things I want to talk about is dose. So how do we determine therapeutic dose? We're talking about these huge amounts of curies disseminated in the environment, but we really don't know what that actual exposure resulted to an individual was. So in pediatric patients, the bottom line is there's actually a lack of evidence to determine how we actually dose patients, but there are several methods that people use across the country and throughout the world. Some people will continue to use an empiric-based dosing, which applies to adults where for a remnant ablation, you might give somewhere between 50 and 100. For local regional disease, maybe 100 to 150, and for distant metastatic disease, 150 to 200 millicurie in the first administration. Some people have used a weight-based dosage scale for children. So as you can imagine, again, that 17 kilogram 5-year-old patient, it's hard to justify giving that patient a full 70 kilo adult dose. So some people will give a weight-based scale where they give 1 to 1.5 millicurie per kilo, or a fractional dose adjustment where you divide the patient's weight divided by an estimated weight of a normal adult and give that fraction of the empiric dose. So all of these methods have been used, and again, there's a lack of evidence to say if any one is better than the other. And then when do we use dosimetry? So that's a tough one, and not every center across the country is equipped to do dosimetry. But the recommendations from the ATA guideline did say that for patients specifically who are very small or who have diffuse pulmonary metastatic disease, dosimetry is recommended. Other than that, the first activity might be based empirically, depending on the size of the patient. So what are the short-term effects of high-dose I-131? The most common short-dose side effect is nausea, vomiting, and that's because of the gastric irritation. Since it's an orally delivered medicine, the dose sits in the stomach and you can have gastric irritation, but that is typically a short-term side effect. Sialadenitis or salivary gland discomfort or pain can occur and actually does occur in a large percentage of adult patients. There have been sort of meta-analyses done that show anywhere from 20 to 73% of adults experience some form of sialadenitis in the acute phase. And we try to recommend lots of fluids, sucking on lemon candies, chewing gum, anything that stimulates the salivary glands to minimize those effects. Short-term effects on fertility might include transient amenorrhea, typically during the first year post-ablation in girls, and decreased spermatogenesis. This is reversible and is generally associated with very high doses over 200 millicurie. And finally, transient bone marrow suppression is something that we can see, but again, this is also with generally higher doses over 200 millicurie, is mild and is typically transient and recoverable. Late effects are a little bit harder to evaluate in kids. So probably the most well-studied and documented late-term side effect is chronic sialadenitis or xerostomia, which is chronic dry mouth. And of those meta-analyses where we said anywhere from 20 to 73% had sialadenitis in the short term, about 35% of the adult survivors of pediatric thyroid cancer had salivary gland dysfunction chronically. That data was from a group in the Netherlands, which looked at a large cohort of adult patients who were diagnosed as pediatric patients with thyroid cancer over 40 plus years. They only identified 105 patients and only 65 of those patients were included. And of those 65, 35% had salivary gland dysfunction. Of those 35%, it's notable that half of them had multiple administrations and a cumulative activity over 150 millicurie. So really, most late-term effects are associated with really higher cumulative doses. Gonadal dysfunctions, again, these are generally temporary infertility in less than a third of women with really no documented long-term infertility side effects. Transient decreases in sperm count, again, have been reported. In some patients, some clinicians will recommend sperm banking if you're planning to give higher doses, especially if you're giving repeated higher doses that might be significant as a cumulative dose. Pulmonary fibrosis, this is one that everyone talks about and everyone worries about because really the bottom line is even distant metastatic thyroid cancer has a very good prognosis, but pulmonary fibrosis can have very serious consequences. So people worry about this. There has been some acute radiation pneumonitis associated with patients who have diffuse metastatic pulmonary disease and subsequent radiation fibrosis that develops. Generally less than 3% have been shown to develop pulmonary fibrosis. So although we talk about it, we worry about it, it's our big concern, it's something that we rarely see. It is generally associated with high dose and repeated therapies. So again, generally doses over 200 to 400 millicurie and multiple cumulative doses. For this reason though, even though it is a very low risk and rarely seen, we do recommend that in patients who have diffuse pulmonary metastatic disease to try and perform dosimetry and limit the whole body dose to the lungs to 80 millicurie retention at 48 hours. Bone marrow suppression or bone marrow aplasia is something that is rarely seen in the long term, but in the short term can be seen transiently as a cytopenia and generally is recoverable. So on to the question that everyone always has when you're talking about exposure to radiation is what's the risk of secondary malignancy? So the primary secondary malignancies that we see in thyroid cancer would be leukemia and solid malignancies, predominantly salivary, renal, and predominantly salivary and renal. So there have been several meta-analyses and analyses done A study in 2009 showed that there was a significant but small increased relative risk of a secondary primary malignancy in patients treated with I-131, which amounted to a 2.5 relative increased risk of leukemia. These patients again received over 400 to 600 millicuries. Another study looking at long-term data in a large population of patients over time showed that 1 in 227 patients over 10 years would develop a secondary primary malignancy in thyroid cancer patients treated with I-131, and a total of 1.7 excess cases of salivary malignancy in 10,000 person years of risk. So the risk of leukemia was noted to be elevated, but not statistically significant. And all of these increased risks were associated with repeated doses approaching 1,000 millicurie total dose. This data was from Marti et al. In 2015, where they looked at over 3,000 pediatric and young adult patients. And again, noted that the absolute increased risk for a second primary malignancy was only 1 in 227 patients over 10 years. And the 3 sites of primary potential increased risk were salivary gland, which was the largest population, and the only statistically significant risk, renal tumors and bone marrow predominantly leukemia. So again, this was this study with really the largest look at the largest volume of patients that were evaluated and the largest person years in risk. This is from the SEER data, which looked at, they ended up with a total of 1,500 patients over 35 years who were pediatric or young adult and got radioactive iodine. Limitations were that the doses that were given to these patients did vary. And the other thing that is interesting to note that in this long 35-year look at patients, only 4% of patients in 1973 got radioactive iodine, but in 2008, 62% got radioactive iodine. So I think in the 80s, 90s, and early 2000s, there was definitely a shift of more universal treatment with radioactive iodine. And I think now we're on the opposite side of that spectrum with really a shift towards selective use of radioactive iodine. And I think we'll continue to see that shift with the upcoming revision of the ATA pediatric guidelines. Bottom line was the relative risk of a second primary malignancy at any site was 4.4 cases in 10,000 person years of risk. So not large, only statistically significant for salivary gland tumors, and every other site was not statistically significant. So just my take-home points and final thoughts. We really need to be careful about weighing the risks and benefits of I-131 administration in children, and the recommendation is to favor selective administration in those populations who would benefit most. I-131 is indicated for the iodine-avid persistent local regional or disease that can't be resected. There is a lack of data regarding dose calculation. Recommendations from the guideline was to consider empiric estimates for the first administration and to reserve dosimetry in patients with diffuse pulmonary metastatic disease or when you get to higher cumulative dose administrations. Outside of that, it was left to the individual treatment team to determine the dose calculation. And the long-term risks as far as secondary primaries is for salivary gland dysfunction and salivary gland tumor development, but these were not considered significant. There was a notable increased risk for leukemia, but again, it was not considered statistically significant and less than 1 case per risk of patient identified. Final thoughts, because there is a very good prognosis for thyroid cancer and a wide variation in therapy and follow-up within and between institutions over time, it is almost impossible to reach definitive conclusions, which makes these discussions very difficult to have with patients and really between institutions. There are no prospective studies, so really we are left with reviewing retrospective data and left with really the task of interpreting that data as best as we can to make the best decision for our patients.
Okay. Thank you very much. Thank you so much for your time. A lot of useful information for us. Again, we appreciate you presenting to us at ThyCa and appreciate your time.